Alright guys, we're going to pick up with some special considerations that we have to take when managing a patient and ventilating a patient. For starters, patients that have a tracheostomy. A tracheostomy is a stoma that is created by cutting through the patient's skin and into the trachea to relieve an obstruction higher up in the trachea, or to serve in place of an ET tube or an endotracheal tube that has been in place for several hours or days. Often a tracheostomy tube, which is a curved hollow tube made of rubber, plastic, or metal, is inserted into the stoma to help hold it open. In a laryngectomy, all or part of the patient's larynx has been removed. In a total laryngectomy, there is no longer any connection of the trachea to the mouth and or nose. The trachea is disconnected from the pharynx, brought forward, and connected to the stoma in the neck. This alters the airway so that the patient breathes completely through the stoma. In a partial laryngectomy, some of the tracheal connection to the mouth and nose remains so that the patient can get some air through the stoma and some through the mouth and or nose. Bring my laser pointer. Alright, so this is a stoma. That's that surgical opening that you will see. There are times where you have to also suction these. If you're having to suction, you want to make sure that you are using a soft tip catheter. In a total laryngectomy, there is no longer any connection, so the larynx has been completely removed, and now the patient, excuse me, is breathing in through this, through their stoma with a tube in place for it. In a partial laryngectomy, the larynx has been partially removed, so now the patient can still breathe in through their trachea, through their mouth or nose, and then still breathe in through that tube. Normally, if patients have had their larynx completely removed, and even with a partial larynx, they'll have to use I can't remember the name of it, but a vibrator that you hold up to your nose, or excuse me, hold up to your throat, and while you're talking, it changes those vibrations into audible sounds. When ventilating a patient through a tracheostomy tube, it may be necessary to seal the patient's mouth and nose to prevent air from escaping. If this is not done, ineffective ventilation can result. If the patient does not have a tracheostomy tube that you can attach to, place your mask from the patient over the stoma and continue to provide bag valve mask ventilations. The bag valve device is designed so that it can connect directly to the tracheostomy tube to provide positive pressure ventilations. All you need to do is remove the mask, and it'll hook up to the connector on the tracheostomy tube, just like the mask would. Now, at times it may be necessary to suction the stoma. If needing to suction the stoma, first you need to make sure that all coverings have been removed, because they may have scars or ties or something to cover the area where the stoma is located. Clear the stoma of any foreign matter that's around the area. All you have to do is just suction. Take your suction around the stoma. Insert your once you're getting ready to clear the stoma, insert the suction catheter approximately 3 to 5 inches into the trachea. Excuse me. And then suction on your way out. You do not need to perform a head tilt or jaw thrust maneuver on these patients because you're going straight into their tracheostomy. All you need to do is just keep their head straight and shoulders slightly elevated. When needing to ventilate the patient, make sure that you select a mask that will fit securely over the stoma. Usually this will be with either a child or infant mask. So you'll use a child or infant mask, but if it's an adult, you'll use an adult bag. With these patients, you'll squeeze the bag, delivering your ventilation over a 2-second period instead of a 1-second period. Make sure you're watching for adequate chest rise and fall, and feel to be sure that the air is escaping back through the stoma during exhalation. If their chest does not rise, you need to suspect a partial laryngectomy, so you need to seal the nose and mouth with one hand so that air will not leak out of the mouth and nose. Pinch off the nose between your third and fourth fingers, seal the lips with the palm of your hand, and place the thumb under the chin and press upward and backward and repeat the ventilation process. It is preferable to use a bag valve mask device with an infant or child-sized mask to form a seal over the stoma. You follow the same procedures as for adult ventilation with a bag valve mask, but form the mask seal over the stoma instead of the mouth. If a BVM is not present and you have no other option, you must use a barrier device over the stoma before you perform mouth-to-stoma ventilation. With infants and children, the child's head should be placed in a neutral position, and then only slightly extended. Because of immature development of the airways, hyperextension of the neck can produce an airway obstruction and collapse the trachea. When providing positive pressure ventilation, regardless of the device or techniques that's being used, it is necessary to avoid excessive ventilation volumes and pressures. Excesses in these areas can potentially lead to gastric distension, which is a common problem while ventilating infants and children. Use a bag valve mask with a minimum volume of 450 to 500 milliliters without a pop-off valve. If a pop-off valve is present, disable it by placing it in a closed or off position. A pop-off valve may unnecessarily vent air and lead to ineffective ventilation. Be sure to make sure that the chest is rising with each ventilation. If you have patients with any kind of facial injuries, such as a blunt force injury to the face, it can cause excessive swelling that may partially or completely occlude the airway. So it may be necessary to insert an airway adjunct to establish and maintain the airway. Also, bleeding into the pharynx can be severe and cause problems with airway management, so make sure that you are prepared to give frequent or constant suctioning if needed. Also, with patients that have mid-face trauma due to the potential for injury to the sinuses and or lower portion of the cranium, you should avoid insertion of a nasopharyngeal airway due to the risk of potentially inserting into that fracture and going either into the sinus cavity or into the cranium. Signs of a severe partial airway obstruction with poor air exchange can be coughing that is becoming more and more silent, a stridorous sound heard on inhalation, or increase in labored breathing. If your patient is responsive and choking but is effectively moving air when inhaling and exhaling, instruct him or her to cough. Do not perform abdominal thrusts or any other foreign body airway obstruction maneuvers. If the patient is 1 year of age or older, perform abdominal thrusts as you would for an adult patient. In an infant who is less than 1 year of age, perform 5 back blows and 5 chest thrusts to relieve the obstruction. It is much easier to establish a tight mask seal with dentures in place. If the dentures are extremely loose, however, remove them so that way they do not dislodge and occlude the airway. Oxygen cylinders come in a variety of sizes. The pressure within these sizes remains constant. So a tank that says 2,000 in a D cylinder and 2,000 in H cylinder, the PSI or the pressure that it's under is the same no matter the size of the tank. However, the amount of oxygen, the liters that it contains within, is different. Such as a D cylinder only has 350 liters, an E cylinder 625, an M cylinder 3,000 liters, G cylinder 5,300 liters, and an H cylinder contains 6,900 liters. To determine how much oxygen is left within the tank, first thing you want to do is take your tank pressure and then measure it by the gauge in PSI minus the safe residual pressure that is always set at 200 PSI times the constant, divided by the flow rate expected to be delivered or being delivered to the patient in liters per minute. This will provide you with how long your tank will last at a desired flow rate for the specified tank, such as using an E-tank for example. You would take 2,000, because we'll say you have 2,000 PSI remaining in your tank, minus 200, which is your safe residual pressure, times your constant, which is 0.28, divided by 15, because you're wanting to set your a number breathed at 15 liters per minute. Okay? So doing the top first, that leaves you with 504 divided by 15. So an E tank at 15 liters would last you approximately 33.6 minutes. There are some safety precautions that you want to take when using oxygen, such as never allowing any combustible materials such as oil or grease to touch the cylinder, regulator, any fittings, valves, or hoses. If oil and oxygen under pressure comes into contact, they could potentially explode. Also, never smoke or allow patients or any others to smoke in any area where oxygen cylinders are in use or on standby, because oxygen could potentially, if a fire does break out or if it gets in contact with any open flame, it can make the fire burn more rapidly. Make sure that you store cylinders in an area where less than 125 degrees, and make sure that you use an oxygen cylinder with a regulator valve that is properly fitted for that tank. Make sure when the cylinder is not in use, or even when it's empty, that all valves remain closed. Make sure also that all cylinders are secured to prevent from toppling over. In transit, they should be either secured to a stretcher or in a carrier tank. They should never be unsecured anywhere in either the patient or driver compartment. When you are working with an oxygen cylinder, never place any part of your body over the cylinder valve. A full cylinder is at 2000 psi, so if the tank becomes punctured or if a valve breaks off, an oxygen cylinder can accelerate with enough force to penetrate concrete walls. And a loosely fitting regulator can be blown off the cylinder with a sufficient force to decapitate a head, penetrate the body, or demolish any objects within its path. There are two types of regulators that may be attached to an oxygen cylinder. A high pressure regulator and therapy regulators. The high pressure regulator can provide 50 psi to power a flow restricted, oxygen powered ventilation device. It has only one gauge, which registers the cylinder contents and a threaded outlet. The therapy regulator can administer oxygen from 0.5 liters per minute up to 25 liters per minute. It typically has two gauges, one indicating the pressure in the tank and the other indicating the measured flow of oxygen being delivered to the patient. It is possible to add moisture to the oxygen by attaching an oxygen humidifier to the regulator. The humidifier, which consists of a container that is filled with sterile water, is connected directly to your regulator. The oxygen device tubing is attached directly to the humidifier. The oxygen leaving the regulator is forced through the water in the humidifier, picking up moisture before exiting and being delivered to your patient. Generally, we'll use humidifiers for long-term therapy. Now, us as EMS providers, we generally don't do humidifying oxygen, just because of what it takes to hook up. However, you may come to a patient's house where they have a O2 humidifier, their oxygen hooked up into a humidifier for them to breathe through. Now, there are some clinical decisions that you want to take in regards to administering oxygen. If your patient, you could potentially provide too much oxygen to patients that have an ischemic stroke or going through acute coronary syndrome that could potentially worsen conditions by releasing free radicals. So any patient, whether if they are presenting with this, titrate your oxygen to maintain an O2 sat of 94%. Any patient that has any signs or symptoms of hypoxia or dyspnea should provide oxygen. So start administering at 2 to 4 liters. So start off low and titrate your way up. It's easier to go up with a dosage versus coming back down with something. With conditions such as ischemic stroke, acute coronary syndrome, and post-resuscitation from cardiac arrest, that make too much oxygen available in the arterial blood may increase the damage to the tissue once perfusion of the ischemic area is achieved. Patients with acute coronary syndrome who are exhibiting evidence of hypoxia or hypoxemia, have a complaint of dyspnea, have signs of heart failure, and have an O2 sat of less than 94% should receive supplemental oxygen. In these cases, a nasal cannula, not a non-rebreather, will be applied, starting with a liter flow of 2 liters per minute and titrated upward based on the patient's response to the oxygen therapy. It is no longer deemed appropriate to provide oxygen by a non-rebreather at 15 liters per minute in an attempt to maximize oxygen concentration in arterial blood. It has also been discovered that the improvement of arterial blood oxygenation via the use of a nasal cannula at 2 to 6 liters per minute is much greater than was thought in the past. Now for patient, once again, indications for oxygen administration: cardiac respiratory arrest, hypoxia, respiratory arrest, respiratory failure, or an O2 sat of less than 94%. Also, any patient that has any medical condition that may cause hypoxia, such as COPD, congestive heart failure, you should also consider putting them on oxygen. If your patient is showing signs of heart failure, such as crackles in their lung fields or pedal edema noted, you should put them on oxygen. If they have signs of poor perfusion, such as tachycardia, cyanosis, ultramental status, put them on oxygen. And if ever in doubt, it is better to err on the side of caution and administer oxygen if you are unsure. Now there is some variations when applying oxygen and our goals for oxygen administration, depending on whether you are dealing with a medical, trauma, or some other consideration patients. Your goal in a patient with a medical condition, such as stroke, seizure, acute coronary syndrome, asthma, is to achieve and maintain an SpO2 of 94% or greater. In the medical patient, it is recommended that a nasal cannula be applied at 2 liters per minute and the liter flow titrated up to achieve an O2 sat of 94. However, the American College of Surgeons recommends that trauma patients with any multi-system injury, hemorrhaging, head, chest, or abdominal injury, multiple fractures, critical fractures such as to the pelvis or femur, or any evidence of hypovolemic shock receive oxygen to establish and maintain an SpO2 reading of 95% or greater. This recommendation is based that trauma patients be given high concentrations of oxygen via non-rebreather mask to achieve as high an SpO2 as possible. The reason for this is because their patient is potentially losing blood, they're losing their ability to perfuse effectively because they're losing red blood cells. So you want to flood the body with as much oxygen as you can, so that way the red blood cells that are remaining are being properly oxygenated. If you have a pregnant patient who is at least 20 weeks gestation or greater, oxygen is often focused on keeping the fetus oxygenated. Therefore, if the pregnant patient has any medical or trauma condition that might cause the fetus to become hypoxic, it is recommended that she receive a high flow of oxygen via non-breather to maximize oxygenation of the fetus regardless of the mother's SpO2. If a patient has been exposed to a toxic substance by inhalation, they should receive a high concentration of oxygen via non-breather at 15 liters regardless of their SpO2 reading. This is because with carbon monoxide, for example, it has a greater affinity to bind to red blood, to your hemoglobin, than oxygen does. So when you are reading an SpO2, it cannot tell the difference at your pulse ox between oxygen and carbon monoxide. So it's going to show 98, 100%, even though they're mostly filled with carbon monoxide. Also, research literature recommends that the goal is to establish and maintain an SpO2 of 88 to 92% in patients with known COPD by titrating the oxygen administration using a nasal cannula. This literature also shows that patients treated with uncontrolled high flow of oxygen has a higher mortality rate compared to those in whom the oxygen administration is titrated. High amounts of oxygen in the blood can cause a decrease in coronary artery blood flow and can increase coronary artery resistance in patients with cardiac disease. In patients with reperfusion conditions such as stroke and acute coronary syndrome, oxygen does have the potential to increase free radical production in the reperfused ischemic tissue that could lead to an increase in tissue damage. Oxygen toxicity, this is a rare event within our environment in the pre-hospital field. However, if you are called to transport a patient to another facility, it may be necessary to use a low concentration delivery device for a patient who has been on oxygen for a long period of time. Oxygen toxicity may cause the alveoli in the lungs to collapse. Damage to the retina of the eye through scar tissue formation may occur in premature newborns with excessive oxygen administration and is known as retinopathy of prematurity. This usually is not a major consideration in the pre-hospital environment, and oxygen should never be held from any infant or any patient with any signs of hypoxia or inadequate breathing. Also, with patients with COPD who are based off the hypoxic drive, respiratory depression or respiratory arrest could occur from administration of high-flow oxygen. In COPD patients, the body responds to low oxygen levels in the blood as a stimulus to breathe. Before administering oxygen, you want to explain to the patient why the oxygen is needed, how it is to be administered, and how the oxygen delivery device will fit on the patient. Make sure that your tank contains oxygen by checking your regulators. Open and shut your valve for 1 second. Place the yoke of the regulator over the valve and tighten it. Open the valve half a turn to check your pressure, and attach tubing to your regulator, set your flow rate, and apply the device to the patient to administer oxygen. When deciding to terminate oxygen therapy, the first thing you want to do is remove the mask or cannula from the patient. Once you have done that, turn off your flow meter, then turn off the cylinder valve. Open the regulator valve to allow the oxygen trapped in the regulator to escape until the pressure gauge reads 0. Turn the regulator flow meter control, then completely off. When transferring oxygen from your portable to your onboard O2, remove the mask from the patient's face before attempting to switch over. This is so that way they are not sucking in nothing. The oxygen tubing can easily become cotton sheets, blankets, straps, or other equipment, and may require a few minutes to untangle. During this time, if no oxygen is flowing to the mask, the patient's tidal volume and blood oxygen content will be drastically reduced. Non-rebreather mask is a device that has an oxygen reservoir bag attached to the mask with a one-way valve between them that prevents the patient's exhaled air from mixing with the oxygen in the reservoir. The mask also has rubber washers that cover the exhalation ports. This allows air to escape on exhalation, but restricts air to flow in the exhalation ports during inhalation. With each inhalation, the patient draws in the contents of the reservoir bag, which is 100% oxygen. Because some ambient air is inhaled from around the edges of the mask, the oxygen concentration delivered is usually around 90%. There are various sized non-rebreather masks available for infants, children, and adults, so ensure that you are applying the correct size mask for your patient. Nasal cannulas we use these for patients that need oxygen between 1 liter to 6 liters. When applying a nasal cannula, once again, explain to the patient what you're doing and that you are delivering oxygen through the prongs that fit in each nostril. Instruct your patient to breathe normally. Prepare your tank and regulator, connect your nasal cannula tubing to the regulator, and set the liter flow at 2 liters per minute. You can titrate up to 6 liters to achieve your desired O2 reading of 94%. Excuse me. Insert the 2 prongs of the cannula into the patient's nostrils with the tab facing down. Follow the curvature of the nose. Position the tubing over and behind each ear. Gently secure it by sliding the adjuster underneath the chin. Don't make it too tight though, because it could become uncomfortable for the patient. And then make sure you check it periodically to ensure that it has not been dislodged. A patient is placed on 1 liter via the nasal cannula inhales an oxygen concentration of approximately 24%. As a general rule, for
every additional liter per minute of flow delivered, the oxygen concentration the patient inhales increases by 4%. There are some other face masks or oxygen delivery devices that you may come across. A simple face mask has no reservoir and can deliver up to 60% oxygen, depending on the patient's tidal volume and the oxygen flow rate. Exhaled air exits through the holes on each side of the mask. The oxygen flow rate is usually set at 10 liters, but must not be set at less than 6. Because it does not deliver as high a concentration of oxygen as the non-rebreather, it is not recommended for pre-hospital use. The partial rebreather mask looks similar to the non-rebreather, but is equipped with a two-way valve that allows the patient to rebreathe about 1/3 of his exhaled air. The flow rate is typically set at 10, but it should not be less than 6. Partial rebreather masks can provide oxygen concentrations between 35 and 60%. Tracheostomy masks are used to deliver aerosolized medication, aerosol therapy, or oxygen to a patient with a tracheostomy tube. A T-tube is commonly used for this purpose. However, the tracheostomy mask is preferred. The advantages of the tracheostomy mask there's less friction being placed on the airway from pooling associated with the T-tube, and also secretions can escape from the tube. The main disadvantage is that the tracheostomy mask delivers only lower concentrations of oxygen, typically less than 50%. If lower oxygen levels can be tolerated by the patient, the tracheostomy mask is the preferred device. The Venturi mask is a low-flow oxygen system that provides precise concentrations of oxygen through an entrainment valve connected to the face mask. The Venturi mask has a variable liter per minute and traditionally delivers between 24 and 50% FiO2. The entrainment valve can be changed to deliver precise oxygen concentrations at preset flow rates. Simple face mask. Remember, this does not have a reservoir and delivers up to 60% oxygen. Partial rebreather. It has that reservoir like with a non-rebreather mask. However, it does not have the covers to prevent you from inhaling outside air. The Venturi mask, it provides precise concentrations of oxygen through an entrainment valve connected to the face mask. So down here is where that entrainment valve is. So you can set it to give 10 liters of oxygen, but only be providing 40% of FiO2. Alright guys, that's it for this chapter. If y'all have any questions, shoot me an email, or shoot me a message in Remind, or just write them down and ask me in class. If y'all need anything, just let me know, and I'll see y'all next day in class.